Hi, so my name is Mary Backhouse. I'm a GP in Aylesey in North Somerset, and I also have the very privileged job of being the Clinical Accountable Officer for North Somerset CCG. So for those of you who may not know North Somerset, this is a map of it. In terms of our population, 2/3 live in our 4 main towns. So we have Weston, Steventon and Portishead on the coast, Aylesey where I work inland. And then the rest of our population live in the rural areas. So it is quite a different area from the Bristol conurbation. In terms of our services, we're co-terminus with our local authorities, so our social services and our community services are delivered on the same footprint. In terms of acute trusts, we have 3 acute trusts. So we have Weston right down in the very bottom of our area, and then 50% of our activity comes into Bristol to UHB and MDT. I felt it was important to give you the context of North Somerset, so I've talked about the geography. I think you also need to understand about our population. So we have a population who has health that is better than the English population as an average, but we have an elderly population, and many CCGs in the southwest would say that. We have a significant elderly population. 20% of our population are already over the age of 65, and that's compared with the England and Wales average of 16%. And we have a very significant number of care homes, so we have twice the number of care home beds per head of population in North Somerset compared with the national average. And as a result of that, we are a net importer of older people into North Somerset. In terms of health inequalities, compared with the Bristol situation, we have relatively low, but they are extreme. And Martin Jones actually did a locum in our most deprived area, and I think it's fair to say you were quite surprised by it. So we have second, third generation unemployed with significant impacts on a whole range of health areas. Drug misuse is also high, and again this is to do with the context of Weston-super-Mare, so we've had 11% of the drug and alcohol rehabilitation units in the country based in Weston, and that has a knock-on effect because people fall out and stay in Weston, or maybe they complete their treatment and then relapse and have remained in the Weston area. In terms of premature death, as everywhere in the country, cardiovascular disease and cancer are our big killers. But our biggest cause of disability in North Somerset is mental health, and we have high suicide rates. This is something that we're working very closely with our mental health provider and with our local authority. But again, it's reflecting of the drug and alcohol population. So talking about our elderly population, I appreciate this is not a particularly easy slide to see, but the filled-in blue area is our population back in 2008. In terms of the bottom line, left hand is 0, right hand is over 90. The solid blue line is our population in 2013, and the dotted green line is our projected population in 2018, which is actually only 3 years away. And you can see the middle-aged and elderly cohort is growing rapidly, and obviously in terms of multiple long-term conditions, in terms of frailty, that has a significant impact. So given that that's our context, what are our strategic priorities as a CCG? So given a challenged environment, we want to develop a model of care that is clinically safe, but is also sustainable. Secondly, we want to achieve financial sustainability. So I have to regularly account to NHS England for the fact that my budget is £10 million in deficit. As a PCT, there were financial problems in North Somerset as well, and so there is constantly that pressure of how do we do more with less. And then thirdly, and for me as a clinician, this is the one that's obviously closest to my heart, I want to improve health outcomes and reduce inequalities. And actually that helps with the financial situation as well. So if you're thinking about how you can work with us as commissioners, I need you to understand my population and my priorities. And our current sort of uppermost priorities are prevention and healthy intervention. And I've just been having a conversation with Mary Backhouse from the HSN. I was with Ian Dodge from NHS England yesterday, and he was saying actually the highest cause of people to be on long-term benefits is mental health and musculoskeletal problems. So how do we make sure that people early on in their illness have easy access to IAP services, so that these are improving access to psychological therapies without having to go through GPs? How do we get open access to physiotherapists to make sure that people actually have early intervention? Self-care, so that's about people making sure that their lifestyles are healthy, both from a physical and a mental health point of view. But if they develop a long-term condition, are they empowered, are they educated to manage that long-term condition as well as they can do? And I think this is a really exciting area, seeing some very exciting work happening on diabetic apps and people self-managing, so really lots of potential. For those people who are further on in their journey, so people with multiple long-term conditions, people with frailty, have they got the appropriate care plans? Are those agreed with the patient and family? Are they co-produced? And are they shared with the clinical population, whether it's the ambulance service, the out-of-hours service, or our fellow clinicians, or our social care colleagues? As with all three CCGs, urgent care is a key priority, as is the appropriate use of planned care. And I've already referred to mental health, CAMS, IAT and dementia are three key priorities for North Somerset. And then the transformation of our provider landscape is going to be key. I'm sure many of you in the room have seen the 5-year forward view that's been brought together by a number of organisations that actually talks about the long term. I'm a GP, I spend up to 4 surgeries in the surgery, and I'm acutely aware of the difficulty not only in my own environment, but in mental health, the district ambulance recruitment, everywhere that there are tensions. So how do we create this new model of integrated care, with care close to people's homes? So we already have 4 integrated teams. 2 are very well established down in the western area. Our ones up in the more rural areas are more virtual teams, but they include mental health, they include social care. The voluntary sector are absolutely key in what is going to be delivered both now, but increasingly so in the future. The number of beds in the hospital, in the hospital system has reduced over the years, and compared with 20 years ago, there's been a very dramatic shift. And there are 2 times as many beds in the care home sector as there are in hospitals. And we need to ensure that all the services that are caring for those people have actually got the right skill set. So that's if you're looking for an area to do some research, it's a really right area. Primary care, community services, we're in the middle of curing ours, so watch this space. And in my part of the world, acute care, so Western again is being required. So that in a nutshell is North Somerset for you.